This video demonstrates robotic total pelvic exenteration with intracorporeal ileal conduit. We have nothing to declare. Our patient is a 37-year-old gentleman who presented to us with bleeding per rectum. On examination, he had an ulcer proliferative growth in the lower rectum, biopsy of which was poorly differentiated adenocarcinoma. He was diagnosed with T4BN1 non-metastatic low rectal growth with loss of fat plane with the prostate and involving the right levator ani muscle. We received concurrent chemoradiation, following which a response scan was done which showed stable disease with persistent loss of fat plane with the prostatic capsule. However, there was response in the nodes. He was then planned for robotic total pelvic exenteration with VY plasty for perineal reconstruction. The port placement is depicted in the diagram. We begin our dissection underneath the IMV, dissecting from medial to lateral, following the avascular plane along the Folds fascia, followed by dissection of the IMA at its origin. The IMA node is cleared of the base and the left colic artery and the superior rectal artery are defined. The left colic artery in this case has been spared just in case we plan to do a sigmoid urinary conduit. Medial to lateral colonic mobilization is completed. The peritoneal cut is extended laterally onto the right side and is extended towards the obliterated umbilical ligament. The right side vas deferens comes into view, which is then clipped and divided. Dissection continues in the avascular plane underneath the superior rectal artery, and mobilization of the rectum in the pelvis is done in the standard TME plane. Dissection is done and the rectum is mobilized off the presacral fascia down to the pelvic floor. Colonic mobilization is completed after scoring the lateral peritoneum and mobilizing the colon till the splenic flexure. We then mobilize the rectum in the pelvis, first scoring the peritoneum on the left lateral aspect. Once the rectum has been dissected away from the lateral pelvic wall, we extend the peritoneal cut onto the left side, just as we did on the right side, and clip and divide the vas deferens. We then dissect along the length of the left ureter, defining the ureterohypogastric fascia. The ureter is dissected along its length and then clipped and divided at its distal end. The ureter is then mobilized for the purpose of future urinary reconstruction. We now focus our attention onto the left pelvic lymph node dissection, clearing the tissue from the external iliac vessels proceeding from lateral to medial fashion. The obturator nerve is identified and preserved. All nodal tissue around the nerve is meticulously cleared. Following this, we direct our attention to dissection along the branches of the internal iliac artery. The lumbosacral trunk has been identified and preserved. Once the dissection along the internal iliac artery has been completed, it is clipped and divided, followed by dissection of the internal iliac vein and clearing on the nodal tissue along the inferior vesical vessels. We can see the obturator nerve and the lumbosacral trunk being identified and preserved. Following this, the right ureter is clipped and divided and mobilized for future urinary reconstruction. The right PLND is done in similar fashion. The obturator nerve and the lumbosacral trunk are identified and preserved on the right side as well. After this, the internal iliac artery and the internal iliac vein on the right side are clipped and divided. Following this, the right hypogastric nerve is sacrificed and dissection is done down to the pelvic floor, clearing all the nodal tissue on the right side. Following this, we mobilize the bladder in the avascular plane in the space of reticeus and divide the dorsal venous complex down at the pelvic floor. Once that is done, we divide the urethra and proceed to fashion the ileal conduit. Ilio-ileal anastomosis is made 25 centimeters from the IC junction, and the ileal conduit is scored for the purpose of ureteroileal anastomosis. We prefer to do the anastomosis in the Bricker's technique, anastomosing both the ureters separately with the loop of the ileum using 5-0 EDS sutures. Two needle drivers are used in order to secure the anastomosis. We proceed to do the posterior wall first, followed by placement of a stent across the anastomosis. Once the stent is placed, we complete the anterior wall circumferentially taking sutures and completing the anastomosis between the ileal loop and the ureter. Once the left anastomosis is completed, we now direct our attention to the right ureteroileal anastomosis, similarly taking sutures along the posterior wall, placing a stent across the anastomosis, and then completing the sutures of the anterior wall. Circumferential sutures are taken, and finally both the walls are closed. Following this, the colon is brought out for sigmoid stoma and the urostomy is brought out as the urostomy. Perineal dissection is done in standard fashion and the specimen is delivered. Bakri balloon is placed in the pelvis to prevent empty pelvis syndrome. This is the post-op picture. The operative time was of 7 hours and blood loss was 700 ml. And the docking time was 8 minutes and console time was 5 hours and 30 minutes. Our patient had an uneventful recovery in the post-operative period and was discharged on post-operative day 10. Histopathology revealed residual disease YPT4N1M0 and all margins were negative. This is a picture of the specimen. Thank you very much for your kind attention.